Hello, future PTAs. So we are going to start our lecture on posture and equilibrium. All right, so a few definitions. Equilibrium is the state where all forces on the body are balanced. The line of gravity is an imaginary vertical line from the center of gravity to the ground. The center of gravity is the point at which your weight is evenly distributed on all sides. And then a plumb line is just any string with a weight on the end will become truly vertical, and you can use that to determine upright posture and to compare for your postural deviations. The center of gravity is, let me see if I can move this. All right, because I'll be looking my cameras to the left. I guess I can't. There we go. Okay. The center of gravity is considered to be anterior to the second sacral vertebrae. That is kind of in the average person, but of course, from one person to another, depending on how they are shaped and where they carry their body weight, the center of gravity is going to be a little bit different. If you're bottom heavy, then it's going to be a little lower. If you've got broad shoulders and small legs, it's going to be a little bit higher. The center of gravity changes as you change positions. If you're standing on one leg or leaning one way, the center of gravity changes, because remember, based on our definition, it is where the point at which weight is evenly distributed on all sides. So if you're leaning to the left, there's a different point that all the weight is distributed around. All right, so factors that can affect stability: your anatomical alignment, your muscle strength, or if you have weaknesses, muscle imbalances, that can all play on your stability. Muscle tone, external forces such as wearing a heavy bag or a bag on one shoulder, high heels, of course, as you see in the picture, and then your standing position or habits. If you're used to looking down at your phone, that's going to affect your stability and any other habits, postural alignment that you have. All right, vertical alignment. So the spine, when it's developing, it's made with curves, and the curves decrease your risk of injury and absorb shock. As you're developing, your primary curve is in an anterior direction. So right here, as you see in a fetal position, the whole curve is in an anterior direction. That's at birth, and this is your primary curve. Now the thoracic and the sacral curves continue to be in an anterior position, so those become named as the primary curves as your spine mature. So initially the whole curve is anterior, the whole spine is anterior and is all called the primary curve. Then as it matures, the thoracic spine and the sacral spine remain in an anterior curve, and they continue to be called primary curves. Secondary curves, though, are the cervical and lumbar spine, the part that we call lordosis. So the primary curves are in kyphosis anteriorly, and then the secondary curves are in lordosis. The cervical and lumbar are in a posterior direction once they mature, and so they're known as the secondary curves. Our anti-gravity muscles, these are the muscles that have to have some sort of tension in them as we're standing in an upright posture. They're responsible for keeping us upright, and they are the neck flexors, our neck and trunk extensors, our trunk extensors. So neck and trunk, the flexors and extensors are both being activated to keep you upright. If you are weaker in the flexors, then you it's going to change your alignment. If you're weaker in the extensors, it's going to change the alignment. Hip extensors and knee extensors are also active in just quiet upright standing to keep you upright. So all of your extensors, neck, trunk, hip, knee, and then also the neck and trunk flexors are active at the same time. Postural sway. Postural sway is what we use in quiet standing to maintain an upright position. So it's small movements that kind of counteract the constant external forces on the body. Typically your ankle and your lower leg are the areas that are primarily responsible for postural sway. So the plantar flexors, the dorsiflexors, they activate just slightly in response to external forces in order to keep you upright. So think about, just an example, think about when you're standing on a bus or on a moving sidewalk or anything like that, that these muscles have to activate as the bus brakes or as the bus starts to accelerate in order to keep you from falling. All right, why is posture important? Good posture decreases the amount of stress on the body. It, of course, increases your function, decreases the amount of energy it takes to do any activity or just to stand upright, and it helps you avoid falls. So maintaining your center of gravity within your base of support is how you avoid falling. All right, standing posture on a lateral view. So if you had a plumb line right beside someone with erect posture, it should be through the earlobe, through the acromial process, through the lumbar spine vertebral bodies, just to the back portion, so the posterior part of the greater trochanter, the posterior, right posterior to the patella. Sorry, I didn't mean to click on that. Posterior to the patella, and then just anterior to the lateral malleolus. So it's basically the middle of the knee joint, middle of the ankle, middle of the hip, the middle of the body. So although it's kind of the back portion of the greater trochanter and the front portion of the lateral malleolus, the line should be directly down the center of the body. Some things that you need to look for in the lateral view are coming now. So you can look at the knees if they have genu recurvatum, so the knees are back too far, too much extension at the knees. Then, of course, the plumb line would be anterior to the knee rather than directly in the middle of the knee joint. So standing next to a plumb line could help you determine if they have genu recurvatum, or of course just testing the range of motion. And if they have more than 5 degrees of hyperextension at the knee, we know that is considered to be genu recurvatum. If someone has tight hamstrings, then this would decrease their knee extension, or if they have decreased knee extension for other reasons, this would cause the plumb line to fall behind the knees. Of course, this is an extreme case. We call this crouch gait, typically in children with cerebral palsy. They have extremely tight hamstrings and tone coming from the brain and other flexor muscles throughout the body. And, of course, the plumb line would then fall well behind the knee. Forward head posture would cause the plumb line to be posterior to the ear rather than directly over the external auditory meatus is what it's called, right? Oh, I don't have it. I just called it the earlobe. That's fine too. Okay, from an anterior point of view, the plumb line should be directly in the middle of the body. So it should directly cut the body in half. So you should have equal portions on both sides, directly between the ears, directly between the shoulders, right between the ASIS. The knees should be the same distance apart from the plumb line. The feet should have equal arches. The toes should be toeing out the same amount on each side. And in towards a neutral position, and then the weight should be evenly distributed. They shouldn't be leaning towards one side. Some of these things are really slight, hard to tell unless they are standing right behind a plumb line. So it's good to have a plumb line in your facility so that you can compare and see if the slight deviations are there. If you notice somebody's ears are uneven, then most likely their head is tilted. It could be torticollis. So this is somebody with torticollis even as an adult that never got treated as a child, and it's not something you outgrow without treatment typically. Some children will, but only if they're really turning their head both ways as they're developing. So if you notice that one ear is lower than the other, then start to look for tight muscles in the neck, especially the sternocleidomastoid, you know that is what causes torticollis, tightness in that muscle. If the shoulders are uneven, one is higher than the other. Of course, we're looking posteriorly, but you can see this from an anterior view as well. Then most likely the upper trap is tighter on one side than the other. Most of the time it's not just tight, it's overdeveloped on one side and maybe even weak on the other. So especially in women that carry a large purse on one side consistently, that side will develop and become a little bit higher than the other. Of course, even men or whoever, if you have a giant bag like this you're carrying around, you're also going to overdevelop one side of the body. The ASIS, if they are uneven, you need to measure the leg length. Remember how we measured leg length from the ASIS to the medial malleolus? Again, this picture is from the posterior view, but you can see it from the anterior view if you're looking for the ASIS. So a true leg length discrepancy is when there is a difference from one side to the other on the actual measurement from the ASIS to the medial malleolus. This person would have a true leg length discrepancy. As you can see, the knee, the crease in the back part of the knee, or even the patella in the front, will be uneven. It'll be lower on one side. The greater trochanters will be uneven. The iliac crest will be uneven. The ASIS will be uneven. All of those things. Now again, if there is an SI joint dysfunction, then it will look like a leg length discrepancy, and so more testing will need to be done to determine if there's a true SI joint dysfunction. So if you measure the legs and they're actually very similar, you know, within a centimeter or two of the same length, then you start to do some SI joint testing to determine if that is rotated and causing it to appear like there's a leg length discrepancy. All right, so another thing you can see from the anterior view is Genuverus. Of course, that's bowing out of the legs, and Genuvalgus, that is caving in of the knees. Knock-kneed would be valgus, bow-legged would be varus, and then overpronation or oversupination. I couldn't find an anterior view of overpronation and oversupination to put as a picture. You can see it from the anterior view. Most of the time we look at it from the posterior view because we have them lay supine and we draw a vertical line on the Achilles tendon, and then we have them stand up and we look at how that line bows in or out to determine if they're overpronating or oversupinating. So that's really the best way to determine it, but you can also see by looking at the forefoot and the amount of contact it has with the ground from an anterior point of view. With the anterior view, another thing is toeing in or toeing out. Remember we talked about hip anteversion and retroversion, that malalignment of the hip can cause toeing in or toeing out. There can also be muscle imbalances and things like that that cause it over time. So you want to look and see if their feet are properly aligned in a neutral position, or if they're going towards toeing in and toeing out, and then compare sides. Is one forward and the other foot toeing in or out more? So always compare one side to the other, whatever view you're looking at. Another thing you can look at from the anterior view, and of course we have it from the lateral view, which I actually prefer for this, is the amount of pelvic tilt. If they have an anterior pelvic tilt, it will increase lumbar lordosis, and a posterior pelvic tilt will decrease or make a flattened lumbar curve. So we'll sometimes call that flat back. So look at the tilt of the pelvis and try and get them in more of a neutral alignment for a proper posture. With the anterior view, we can also see, it's interesting they put this with anterior view because I would probably look more at a posterior view, a pelvic drop if there's weak gluteus medius. And I do want you to be aware, something we haven't covered a lot, but when one gluteus medius, so if they're standing on the right leg here and the right gluteus medius is contracting, the left quadratus lumborum also contracts to steady the pelvis. Now, typically the gluteus medius is weak and the quadratus lumborum is tight, so it might be overcompensating and actually even maybe doing a hip hike on that side, which is a compensation for that Trendelenburg gait or posture when the pelvis tends to drop because of a weak gluteus medius. And also notice that the adductors have to activate on that side as well to kind of stabilize everything as you're doing a single leg stance. So that's a co-contraction between the gluteus medius and the quadratus lumborum when you're standing on one leg. All right, so some of the things we look for in a posterior view. Again, the plumb line should really fall in the middle of the body and your weight should be evenly distributed on both sides. You can compare the shoulders, the ears, look for scapular winging, and make sure that the scapula are even on both sides. Look at the PSIS position, make sure there's not a rotation or an even alignment there. Look at the gluteal folds. I have a picture of this coming. And then knee position and the calcaneus position. This is, again, what I was talking about with drawing a line in prone and then looking in a weight-bearing position at whether the person is overpronating, oversupinating, or has a good postural alignment there. This person, of course, would be overpronating on both sides, with the left more severe, more significant than the right. Scapular winging. This can occur with a weak serratus anterior, which is innervated by the long thoracic nerve. And the way that we typically remember that is SALT, serratus anterior, long thoracic, SALT. If the long thoracic nerve has been damaged or if the serratus anterior is weak, you will see scapular winging. Oftentimes you'll see it on one side more prominent than the other. And remember the push-up plus, that after you do a push-up and you're back on the all fours, kind of a plank position, if you then retract your shoulder blades and then go back to a neutral alignment, that's the plus portion of the push-up. That is what's strengthening that serratus anterior, the pushing forward of the shoulder. And so really it's scapular protraction. Retraction is your rhomboids. Protraction, separating the shoulder blades in the back and pushing the shoulders forward, the arms forward, is the serratus anterior. So if you do notice scapular winging and it's not a nerve injury, if it's a nerve injury and they have no movement, then you really can't strengthen. But if the nerve is intact and they are able to move it some, that's a great way to begin to strengthen. You can have them lay in prone and do a serratus punch, just punching forward, or you can have them do a push-up plus, be in a plank position and do some protraction there. Something else to look for is scoliosis. So if they're standing upright, you look for the level of the shoulder and the shoulder blades. You look for a straight line versus a curved line. You look for the level of the hips. As you see with this case of scoliosis, it's pretty severe. She's compensating to the point where the shoulders look somewhat aligned. You can tell the ribs and all that is not, and then you can see a big difference in the height of the iliac crest in the back. You can see with that line trending down. As you may remember from physicals when you were a child, they have you bend over to touch your toes and they look at your back. What they're looking for is one side to rise up higher than the other. And if, now this is an extreme case, if one side rises up higher than the other, that is a sign of scoliosis. So sometimes, like maybe a patient more like this that has maybe a slight curve and you can't really tell in an upright position, when they bend forward, it becomes more prominent. So that's a test that we often do to rule out or in scoliosis to determine if someone has that. The gluteal fold, as I mentioned, can be uneven. So as you see, her gluteal fold on the right is significantly higher than the left. It could be a sign of a postural imbalance, like maybe they always stand on one leg or lean towards one side. It could be a sign that they're training improperly, that they're always running in one direction, doing more reps on one side than the other, always standing with one leg slightly forward. A lot of times gymnasts and really there's a lot of sports that you have somewhat of a staggered stance and you typically push off of one leg. You have a kind of a stronger leg you push off of, and that can also build up one side. And it may also just be developmental. Some people with larger butts will have just one side that's significantly larger than the other, and there's no training you can do. This person, there's probably no amount of training you could do to fully even that out. So it could also just be the way that they're built. But I would certainly look for the training errors and stuff to correct that. With our sitting posture greatly affects the amount of pressure on your intervertebral disc. So if you are sitting upright with proper support, then the intervertebral disc will only be absorbing the amount of pressure coming from the head. If your head is 12 pounds, there will only be 12 pounds of weight being absorbed by the intervertebral disc. However, if you're slouched, like I am now, and we probably all are sitting and watching this video, there is a great increase in the amount of pressure. As you see here, the estimation was 36 pounds of pressure on the intervertebral disc just by leaning forward. This is one reason why it's great to have lumbar support in your chairs and to sit upright in order to decrease the amount of weight on those discs. Especially for people who are sitting the majority of the day. If you're sitting for long periods of time, it's even more important to have an upright position. And then just a little note for people, of course, you all know the whole flexion bias, extension bias situation. That's with people who have herniated disc, herniated nucleus pulposus. And so typically they will prefer a flex position. People with facet joint issues also prefer a flexed position. However, it's typically better to treat an extension. Remember that typically helps correct a herniated disc or a bulging disc. Now with the facet joint problem, you need to properly align and treat the facet joint issue and then encourage an upright or erect posture. So even if a slouch position is preferred, it's a position of comfort, we still want to eventually get to a point where they can tolerate an upright position because it's going to be a better position for their back. All right, so for ergonomics, in order to do an ergonomic assessment, one of the things I have in another slide later that we would do is maybe look at them in their home environment or their work environment and assess and see, what we need to change or recommend to get their proper alignment while they're sitting. But if you can at least have somebody take a picture of them sitting at their workspace so that then you can tell them what to do. So the proper alignment, you want the feet flat on the floor. Knees and hips need to be at 90-degree angles. We certainly want lumbar support or a slightly anterior leaning chair. Of course, mine is extremely posterior, so I'm always leaning forward, which is probably not best for my disc, but the trunk and the neck need to be upright. Again, that's going to place less pressure on the disc. The elbows need to be close to the body and relax down towards the side with the elbows bent at a 90-degree angle or parallel to the ground. Wrist and hands need to be in a neutral alignment. Remember, if you extend the wrist too much and keep them there long term, that will cause carpal tunnel. And then the top of the computer screen needs to be at or slightly above eye level. So they don't need to be looking way up or way down at their device. So with laptops, almost always the screen is too low, so be careful with that. A lot of desks are not adjustable, so adjusting the chair would be good, but if the chair then it becomes too high and their feet aren't touching the ground or their legs are too extended, you can put like a step or something under their feet in order to adjust that way. Since most people's desks are not adjustable, it's typically the chair. All right, our supine position, when we're laying, supine position has the least amount of pressure on your intervertebral disc, so that would be the ideal position. Even in babies, there was a big push for back to sleep, meaning put them on their backs to go to sleep. That kind of changes every few years. For a while, it was on the stomachs until SID, sudden infant death syndrome, increased, and then they were saying on the sides and then on the back. So I personally say be cautious and use your judgment. But as far as for adults, the ideal sleeping position would be supine. That's when the least amount of pressure is on your intervertebral disc. You want your mattress to be firm enough in order to maintain your lumbar curve, but soft enough in order to still support your spinal curves. So a good mix of soft and firm is ideal. Your pillow height should be just high enough to maintain your neck's proper alignment. It needs to be in a neutral position without overly flexing the neck. And then when you're laying on your side, it also needs to be high enough to keep you in a neutral alignment without side bending one way or the other too much. Speaking of side lying, if you are side lying, it's ideal to have the bottom leg straight, top leg bent and supported with a pillow underneath to maintain good hip and knee alignment. And then prone is really the last position that we recommend because it creates poor postural alignment, and there's not really a way to get somebody in a good prone position for long term, maybe for a short term position, for, of course, manual therapy and things like that, but not for sleeping long term. All right, so on a whole different topic for just a second, there are primitive reflexes that help maintain our postural control and our equilibrium to keep us in an upright position. So almost all of the primitive reflexes, as far as equilibrium go, are to keep the head in an upright position and the eyes vertical to the ground. So one of them is righting reactions. So these are automatic reactions to weight shifts that keep the eyes upright. So as you lean a baby to the side, their head automatically side bends the opposite way in order to keep their eyes level with the ground so that they're always able to see at, a flat surface, not all crooked. So it's trying to bring the head to an upright position and bring the head and trunk in alignment to each other. So if you tilt them one way, they may also kind of push their trunk back to an upright position. There's some video links here so that you can kind of see this in action. And then the equilibrium response. So these are automatic patterns of movement. They start to develop around 6 months old that help you maintain balance and shift your center of gravity over a base of support. So that's why typically a child will begin to sit upright at around 6 months old. Whenever you try and sit them upright at a younger age, for one, they don't have the core strength to be able to maintain that position. And two, they also don't have these equilibrium responses that help them shift their weight to stay upright. And so most of the time they just kind of tilt back and eventually fall over. But once they have enough core control and the equilibrium responses, they are able to kind of shift their weight, maintain their center of gravity over their base of support. Things that elicit the equilibrium responses or bring them about are changes in internal and external forces on the body, or enticements outside of oneself, which would be like they see something they want and they want to lean to get it. So these are primitive reflexes in children that help them maintain their equilibrium. Okay, so a few more general guidelines. So with balance, you want to assess a patient's ability to maintain posture in various bases of support. So have them stand with their legs wide apart, narrow, maybe tandem, one in front of the other. You want to assess balance with movements, and in a static position, you want to assess it on various surfaces. That's why we do the foam versus a hard surface, indoors versus outdoors. All those are important in determining the patient's balance. Length measurements, of course, you want to look at leg length. We already spoke about that. Alignment, you always want to compare one side to the other to look at differences or common things. Even in poor alignment might be the same on both sides, which might tell you it's more structural than a muscle imbalance. Muscle tightness, you always want to look and see what muscles have tone and what could be contributing to their postural deficits. It's one of those things, what came first, the chicken or the egg? Was the muscle tight and that caused poor posture? Did they have poor posture and that caused the muscle to be tight? Either way, you want to hit it at both ends and correct the posture and decrease the muscle tone. And of course, whatever's tight, the antagonist muscle is most likely weak, and so strengthening that antagonist muscle. So if they have extremely tight hamstrings, you want to stretch the hamstrings and strengthen the quads. If they are leaning forward, you might want to stretch the abdominal muscles and strengthen the back extensors. And then weakness, again, for compensation for poor posture alignment. Sometimes if one muscle is weak, they'll compensate by another. So, look for the tight muscles may be the compensation and the opposite muscle would be the weak. All right, some of the common postural deviations. The first one is kind of your normal posture from a posterior aspect. And of course, the next one is scoliosis. Then this third picture is your normal posture from a lateral view. Again, we have the primary curves, which would be thoracic and sacral, which are in an anterior direction. We have the secondary curves or lordotic curves, which is your cervical and lumbar curves. They are in a posterior direction. Too much of an anterior curve is kyphosis. Too much of a posterior curve is lordosis. And not enough curve would be a flat back. All those are written below if you want to reference this slide later. All right, so one of the common postural deviations these days is text neck, where you're always looking down and begin to develop some tightness in the front, some weakness in the back. So, of course, look at that with some of your patients with muscle imbalances of the neck. Remember, forward head posture is also a very common posture where there is lower cervical flexion, and then they want to look upright, so they end up doing upper cervical extension. So the upper cervical extensors are tight, those suboccipital muscles, and the lower cervical extensors are weak. So that chin tuck is the best way to counteract that posture. All right, just two more slides. We're almost there. So postural awareness trainings, the object here is to strengthen the weak muscles, stretch the tight muscles, as always. But some of the things that can help you do this are objects to help them increase their awareness. You cannot correct a poor postural alignment if you aren't aware of the malalignment. So a plumb line, having the person stand behind it, and you could take a picture of them and show them, or use it yourself to help determine what is off. Mirrors are helpful, especially drawing a line in the center of the mirror so they can look at it and see, oh, I'm leaning to the left, or I'm tilted this way. Pictures and videos are very helpful with postural awareness training, as well as gait training and balance training, all of those things, because sometimes habits are not easy to be aware of. They're unconscious, and most people, posture itself is mostly a habit and an unconscious habit at that. So helping them become aware of the issues is key. You want to also look at ergonomic adjustments and training adjustments. So if somebody is training the wrong way, you remember some of the common training errors: running the same way all the time, not switching up directions, running on uneven surfaces, even poor shoes. They're already worn out and they're causing your postural deviations to become even worse, less support. All of these can lead to poor posture and muscle imbalances. in general, the posture muscles are typically weak. And so when you are strengthening them, you have to really start low and gradually build up. So you can't say, hold this for 30 seconds or do 400 reps. I mean, you have to start really low and then build up. And typically, kind of like we mentioned with pelvic floor physical therapy, you want to kind of increase the duration or how long they hold an exercise rather than the reps initially. So, hold this for 5 seconds, do 10 times. And then as you progress, you might say, now hold for 10 seconds and do 10 times before you ever say do 30 times. They wear out easily, and you can also get very sore if you overwork your postural muscles. But we want to gradually increase the amount of time they do the exercise, so duration, and then increase reps, but we typically don't put a lot of weight on postural reeducation. Some of the things that we do in addition to stretching, we can do manual therapy, modalities, ergonomic adjustments, again, the pictures and different things like that to help them become more aware and change their habits. And I think I've said all of these things. Yep, evenly train on both sides. Okay. So we can go over in class some different things that we do for postural awareness training. And then for balance training, remember there's static versus balance, so standing still versus moving on even surfaces versus uneven surfaces or foam, more mobile surfaces that move underneath you or are less stable. Anticipatory balance control, so having somebody, they could tighten up before they are pushed, and training for tightening up before the brakes are put on while standing on the bus, things like that. So perturbations, given those small little pushes, can help train that. Also, having them lean different directions. One of the things we like to do is do like kind of a clock where they're standing on one leg and they're using the other leg to reach towards different numbers on the clock or different surfaces on the floor, in order to try and work on kind of leaning outside of the base of support in single leg stance. That's a pretty advanced activity. Reactive balance control, so reacting to changes in the environment, leaning side to side, weight shifting, even keeping their legs erect and just leaning their trunk outside of their base of support. Reaching, grasping, and moving objects is good for that as well. Sensory organization, so kind of taking in the environment. So you might work in a closed environment first and then a more busy environment with people around. You could put busy patterns on the wall or have them do things in front of something that's moving, whether it's a TV or if there's traffic outside the window, so that they get used to being able to process different sensory input as they are working on their balance and be able to maintain their balance. Balance during functional activities. I really like dual tasking, like walking while holding a tray or a cup of water. Walk while talk. That's difficult for a lot of people because they typically focus so much on the walking, it's hard to talk. Vacuuming, sweeping, things like that are all great functional activities that require a significant amount of balance. And then safety during gait, locomotion, balance, all that stuff. Of course, make sure they have the gait belt on, make sure that you are close by, but also teaching them, to, if they're ever at home trying to work on balance, maybe do seated balance or do balance activities in a corner. So if they start to fall, they can just lean back against the corner. Some of the ways that we can change balance activities is changing the surface. We can do weight shifts, front to back or side to side. Calf raises and toe lifts are good. Even seated, you can tap your toes and tap your heels and work on those in a seated position, seated marching. Closing the eyes and opening the eyes can change balance. So if you're wanting to progress an activity, you could just have them do it with the eyes closed and that will be significantly more hard. Doing things with head turns laterally and vertically, so nodding yes or shaking the head no while walking or while standing still is a great balance activity. Reaching outside of your base of support. Balloon hitting. Balloon hitting is great. My patients love it. They always have fun doing it, and it's slow enough that they can be successful versus like hitting a volleyball or something is typically way too fast. Lunges, squats, tandem standing, standing with your external pushes or perturbations are all great ways of increasing your balance. Now, other walking activities, they can walk on various surfaces, indoor, outdoor, over stones, over sand, stairs, changing their speed. Sometimes you can do like red light, green light, yellow light to change their gait speed, or do sudden starts and stops. Those are typically pretty difficult. Walking on a line, that would be like tandem walking. Backwards walking, remember walking backwards is a great way to eccentrically strengthen your muscles that you use in gait. So it's a great exercise to do. Of course, you can walk with head turns, walk with high knees, larger steps, walk side to side, do the grapevine, go between converging lines. We've talked about with Parkinson's disease that often causes people with freezing of gait to freeze up. So that can be a way to help them overcome that. Stepping over cones, around cones, picking the cones up, all kinds of variations. Whatever you put your mind to, you can do with balance training. So these are just a few of the examples of ways that we can help train people with postural deficits or with balance issues, difficulty with their equilibrium. And we will practice these in class. We'll also learn a lot more about the balance training and some of the vestibular stuff in rehab too. So thank you all for joining me for our posture and equilibrium lesson today. If you have questions, please let me know, reach out, and I will see you all in class.